My name is Sabrina Bashanio, and I am a pharmacy student,
My name is Jenny Nguyen. I'm an optometry student.
and this is our IPE case presentation. Our patient is a 75-year-old female who presents with concerns about her ocular health. The patient is worried that her blurred vision may progress and is wondering if she can prevent it. Our patient ME presents with the following information. Her chief complaint: I don't want my blurry vision to get any worse. The patient's history of her present illness: she has a history of cataracts resulting in chronic blur. She also has suffered from symptoms of dryness in both eyes, with ptosis as a possible contributing factor. Her prior medical history consists of COPD, hypertension, hyperlipidemia, anxiety, arthritis, and cataracts. Her family history includes heart attack, stroke, diabetes, cancer, and glaucoma. Her social history: patient is unemployed and lives with her son. She smoked 2 to 3 packs per day for 35 years and quit in 1993. She drinks 3 to 4 alcoholic beverages per week, exercises a half hour per day, and she does not need assistance with activities of daily living at this time. She has no known drug allergies and reports no food allergies. Upon review of symptoms, she presents positive with blurry vision in her right eye, cataracts in both eyes, dry eye in both eyes, nasal congestion. She does not have swollen glands. She presents positive for cough and shortness of breath, and negative for wheezing, sputum, and cigarette smoking. She is positive for constipation. She has also been urinating frequently, experiencing burning upon urination, and difficulty holding or controlling urine, as well as nocturia. She is positive for joint aches, muscle weakness, and muscle cramps, and she is negative for difficulty breathing when lying flat, as well as negative for chest pain. Our patient ME has the following medications. She takes Spiriva and ProAir for her COPD, atenolol, nifedipine ER, Benicar for her hypertension. She takes aspirin for cardioprotection, ibuprofen and Tylenol for her arthritis, alprazolam for her anxiety, and cholestyramine for her cholesterol. Upon review of our patient's symptoms and medications, we have developed the following problem list. Our patient has been non-compliant with her Spiriva and her cholestyramine, resulting in failure to receive drug therapy appropriately. Also, due to her urinary symptoms, she will need additional follow-up and laboratory monitoring. We suggest a urinalysis as well as a culture to consider potential causes of her urinary symptoms. We have also noticed a clinically significant drug interaction between aspirin and ibuprofen. Taking both of these together can decrease the cardioprotective effects of aspirin and increase her risk of bleeding. The patient is also concerned about her medications for her hypertension. She would like to be on less medications. I suggest further monitoring and evaluation of her blood pressure medications. There is also a drug interaction between Benicar and ibuprofen. Both of these together may decrease her renal function, which is already compromised in the elderly. I suggest monitoring of her serum creatinine, BUN, and potassium. Lastly, the ibuprofen is not optimal for treatment of her arthritis because she is over 75. A topical NSAID is preferred, but ideally I would like to switch this to Tylenol.
Regarding ME's ocular health, the following information was taken into account. Her chief complaint was that she did not want her blurry vision to get any worse. Regarding her history of present illness, she presents with history of cataracts, which results in chronic blur. She has suffered from symptoms of dryness in both eyes, with ptosis as a possible contributing factor. Regarding her prior medical history, she had hypertension and hyperlipidemia, as well as cataracts. In her family history, both her mother and her brother had glaucoma. Her Regarding her social history, Emmy smoked 2 to 3 packs per day for 35 years and quit smoking cigarettes in 1993. She has no known drug allergies and has no reported food allergies. She complains of positive blurry vision in the right eye, cataracts in both eyes, dryness in both eyes, and nasal congestion. She does not smoke cigarettes anymore. Upon examination of Emmy, the following objective data could be obtained. 1. Hyperopia. Hyperopia would be diagnosed based on refractive error assessed during refraction. We were provided with a copy of the patient's last prescription. 2. Amblyopia. Based on the refractive error assessed, the patient would be deemed amblyopic if the two eyes have refractive errors that are unusually disproportionate. 3. Cataracts. Cataracts would be observed during a dilated slit lamp examination of the anterior segment. Based on opacification pattern of the cataracts, the grade and specific type of cataract would be diagnosed. 4. Ptosis. Ptosis would be evident based on gross visual examination of the patient's facial features. 5. Dry eye. Dry eye syndrome would be assessed with a dry eye workup, which includes TBUT, tear breakup time, an epithelial staining with sodium fluorescein, a Schirmer tear testing of the aqueous tear production, and testing meibomian gland dysfunction via expression of glands to assess lipid tear quality. Upon overall assessment of the patient's case, it reveals that she is non-compliant with her cholesterol medication, cholestyramine. If the patient's cholesterol levels become uncontrolled, this could have ocular manifestations such as Hollenhorst plaques, which are cholesterol emboli that have been liberated and subsequently relocated to retinal arterioles. This can lead to transient loss of vision as well as accumulation in the retinal vessels, which would lead to hypoperfusion retinopathy and ultimately ocular ischemia. Regarding Emmy's ocular assessment, her chief visual complaint is common for a 75-year-old patient, where blurry vision is caused by a combination of hyperopia, cataracts, inferior lid ptosis, and dry eye. 1. Hyperopia. The patient's latest eyeglass prescription for bifocals was provided. Her prescription is unusual in that her right eye has a much higher refractive error than her left eye. 2. Amblyopia. The patient's eyeglass prescription shows a disproportionate correction between the right and left eyes. The right eye requires plus 0.75 more spherical power and minus 0.50 more cylindrical power than the left eye. 3. Cataracts. Cataracts were reported by the patient based on previous evaluation by her eye care provider. The patient reports that her optometrist saw early signs of cataracts, which were not severe enough to warrant surgery. 4. Ptosis. Upon visual examination of the patient, an inferior lid ptosis is evident. 5. Dry eye. The patient listed discomfort from dry eyes in her review of systems. The dry eye is likely caused by the inferior lid ptosis, which causes exposure keratopathy and subsequent tear film disruption, leading to eye dryness. Our goal is to address the ocular complaints of blurry vision and dry eye. Dry eye is a factor that exacerbates blurry vision and once addressed will ultimately improve the quality of vision. Regarding her treatment plan and monitoring parameters. 1. Hyperopia. Patient is given a spectacle correction for bifocals. 2. Amblyopia. Spectacle correction will address amblyopia as well. 3. Cataracts. Patient was educated regarding the importance of wearing sunglasses outside to slow the progression of cataracts. The patient is advised to return to the clinic in 1 year for annual monitoring of cataract progression. 4. Ptosis. Inferior lid ptosis is not extreme enough to warrant lid surgery at this time. The patient is to return to the clinic in 1 year for annual monitoring of lid ptosis. 5. Dry eye. The patient is instructed to use preservative-free artificial tears as needed for her dry eye. Patient is to return to the clinic in 1 year for her annual checkup or if her symptoms persist. Emmy was educated regarding 3 areas: her medication noncompliance, her cataract progression, and ptosis and dry eye. To address her noncompliance with cholestyramine, she was educated regarding the importance of taking her medication as prescribed to control her cholesterol levels, which will prevent further complications with her ocular health. She is instructed to continue taking her blood pressure medication as prescribed in order to prevent complications as well. Regarding her cataract progression, she was educated regarding her early signs of cataracts and was advised to wear sunglasses when outdoors or exposed to any UV light to slow the progression of her cataracts. Regarding her ptosis and dry eye, she was educated regarding her ptosis and the likelihood that her dry eye is a direct cause of the ptosis. She is advised to use preservative-free artificial tears as needed to address her dry eye and is instructed to return to the clinic if her symptoms persist to discuss other options.
Being able to work with an optometry student has given me the opportunity to give my patient a proper assessment of their ocular health, as well as the resources to provide them with the best follow-up care in order to maintain their vision. Working with other disciplines provides a patient with direction from a medication management perspective, as well as for outpatient services to provide them with the best overall health care.
Being able to work with a pharmacy student when assessing a patient's case has been very insightful. I was able to see a different side of patient care. For example, Emmy's noncompliance was an issue I would not have previously considered when assessing her ocular complaints. As an optometrist, I would have focused almost entirely on her blurry vision and dry eye syndromes, and although I would have obtained her medication list, I would have not found out that she was noncompliant. This could result in her next eye examination 1 year later with devastating ocular complications as a result of uncontrolled high cholesterol.
Thank you for giving us the opportunity to work together in order to provide ME with the proper multi-center patient health care.